Hello, everyone. Today we are going to discuss a topic which is very popular and also a topic around which we think lots of misinformation is surrounding. The topic is sciatica. Sciatica is, I don't know if it should be something very well known, even though the data suggests not as common as people make it out to be. But nevertheless, it's a very popular term, not just among physios, but also among general public. So we are going to discuss about what is sciatica and why, what are all the problems surrounding it, and especially what are all the common misinformation about sciatica. And at the end, we will discuss about how sciatica can be managed based upon what we know from the current evidence. We have Mr. Hariom with us as usual. Let's start by asking what sciatica actually means.
uh, it's fairly uh, confusing, I think, in terms of if you see it, if you go by the what you see in the clinical setting, that seem to be any person with pain in the leg and thighs and back of the leg or calf muscles are thought to be sciatica. But we will just think of it as a very simple idea. If something happens to a nerve and if it leads to pain, we call it as radiculopathy. Right? Any nerve which is compressed and you get a group of symptoms. Sorry.
You mean to say that the term sciatica is not appropriate?
Not really, but I'm just trying to make an overall assumption about to make it clearer that if a nerve is compressed, you will get at least three types of symptoms depending on the type of the nerve. If it is a sensory nerve, you will get sensory symptoms. If it's a motor nerve, you will get motor symptoms. If it is a combination of all these things, you will get sensory motor symptoms. And then sometimes you will get pain. So if these three things are there in the lumbar region and the lower limb, we have a separate name for that. We could call it as sciatica.
My concern with the term is it suggests a sciatic nerve. Okay. A sciatic nerve is where multiple spinal roots forms together and which is referred to as a sciatic nerve, right? But at the cause often is at the spinal nerve roots, isn't it? So why is it sciatica?
I don't know I mean,
because the sciatic nerve forms outside. I mean, the nerve roots get together. So does
anyway they all are going to get they are going to form the sciatic nerve, I suppose. I really don't know the reason for the names and things like that. Probably there was a there is a common that's the common nerve which can be compressed, I suppose. It's very rarely your femoral nerve gets compressed or something like that. Mostly out of all the radiculopathies you get in the lower limb, sciatica is the common radiculopathy you get.
Right. Moving on. The common reason for sciatica, which is textbook or what clinically explained, is that a mechanical cause. That is the nerve, or in this case, nerve roots or whatever, is mechanically compressed. Right. Either mostly because of a prolapsed disc, which prolapses on the lateral, posterolateral, and the prolapsed part of the disc physically compressing on the nerve roots, which in turn leads to a pain. Right. So what are your thoughts? What does the current evidence suggest?
It's not the current evidence. Always the evidence suggests that the nerve roots are something happens to the nerve roots. There's no question about it. There may be a compression also. That much is clear. But if you see any compression, whether it is the radial nerve or the facial nerve or any compressive sort of pathology you study, you get sensory motor symptoms, or that's why I told, depending on the nerve, you get that kind of symptoms. You rarely get pain. Even if you get a pain, it is slightly lesser. Even if you have Bell's palsy, sometimes you may get pain, but it is not a major symptom. But here, the major symptom is pain, along with sensory motor symptoms. The pain, it seems, is not necessarily from the compression of the nerve as such, because as we already discussed, if a nerve is compressed, mostly you get sensory motor symptoms.
So what causes pain?
It's not very clear, but it seems that there is a chemical reaction which happens in that region. That is where the nerve is compressed. Again, why this happens only in the roots of the nerves, we are not very sure. Again, in Bell's palsy, there is avulsion of the root and things like that, but you don't get much of pain, probably because the whole root is avulsed. But here you get pain. There is a chemical reaction which happens surrounding that region, and they say it sort of irritate the nerve roots, and that may cause, that is the hypothesis now, that they cause the pain.
By chemical reaction, you mean inflammatory process?
Correct. Again, it's not necessarily a simple chemical reaction or inflammatory process, because inflammatory process may have a time limitation. So there is a inflammatory process, but it seems to be far more complicated or different than other places.
Right. So nevertheless, if you look at from the physiotherapy point of view, most of our treatment rarely address the pathophysiology. But however, sciatica, the treatment for sciatica is one treatment where our treatment, we often hypothesize that it addresses at the pathophysiology level. Say, for example, we are trying to treat by reducing the compression by giving a traction or any other exercises as such. So how do you look at these treatments?
Now, the idea looks very, very plausible, right? That is, nerve is compressed, then you pull it. So I would suggest people who are listening to it do a simple experiment. You can hold your finger like this and sort of pull it like this, right? With all your might. You can actually feel a small distraction inside your. If you keep your hand on this joint and then pull it, you can see that the joint sort of distracts, right? Now, remember, this is one of the smallest joints, and here I am sort of putting probably around 25 kilograms to 50 kilograms of pressure, depending on how much I can pull. You can ask other people also to pull it, and you can see the distraction ones. Now, the first thing you will notice after you leave it, it comes to its original. It doesn't stay like that. Otherwise, every time you keep on pulling it, your fingers will become longer. That cannot happen. So the first myth is that you can distract a joint and they will be distracted. Right? Now, the difference between this small joint and the larger back joints are, you would have studied that there are so many muscles in the back, there are so many ligaments, especially the nuchal ligament, the flavum, and all those things which are crisscrossing from here to here. All these ligaments, which are important to keep us straight, they don't yield to this sort of distracting and then coming back. And there is always Newton's third law. Say, for example, for every action, there is a equal and opposite reaction. So your force should be unequal. That is, if you're pulling, this should be more than this one, right? Then only you can pull it. If it is equal, then every time you pull, this will also sort of come together, because there will be an equal and opposite reaction by the elastic properties of the ligaments, the muscles, and all those things. So this is the first flawed argument in the decompression therapy, I suppose. They also have nowadays a decompression therapy. A lot of people are saying that we decompress and things like that. So when you stand up, if say for example I'm 82 kilograms, if you stand up, then my weight is 82 kilograms. That means that I'm being pressed by 82 kilograms, and then there is a equal and opposite force from the ground towards me. So it doesn't decompress anything. And the next thing you will notice is, even if we assume that this is okay, some people, when I say this, some people come and tell me that no, when it decompress for sort of microseconds or something like that, then the mechanical compression which is happening is going away. Again, it doesn't happen like that, because after that your sensory symptoms will not go away, sensory motor symptoms will not go away. And also the pain is far more chemical in nature. This distraction does not change anything much.
Right. So basically, what you're saying is physiologically, decompression is less likely.
Yes.
Right. So just a disclaimer for who was listened to this example. If you stretch your finger and beyond what is dictated by common sense, we are not responsible. Right. Right. So because we because this is a biological structure, and our biological structure, of course, we learn in biomechanics, there is elastin and other components in there. When you stretch it, it will eventually get back unless you really stretch it hard. And do keep in mind, if you really stretch it hard, it doesn't go back. That's also is a problem. Right. So it's a lose-lose situation in any way. If you remember the stress strain curve, you want that to be elastic, you want that to get back to its position. So even though this decompression from the mechanical compression point of view sounds plausible, except that a biological structure such as the joints and ligaments, everything associated with it, it is possibly not possible to decompress. And the next argument that comes is, but when you give traction, patients actually feel better.
I think that is because we overdiagnose sciatica. In my clinic, my practice is relatively smaller. I have sciatica patients left and right. That's not possible at all. That's what I said. The first instance, people don't understand what is a sciatica. Sciatica, by definition, should be a radiculopathy. That is, it should have sensory motor, some sensory motor disturbance along with pain. And the pain, what you get when you have
I'm sorry, when you said sensory motor symptoms, you mean some form of numbness and weakness?
Yes, again, I'm not talking about numbness as patient tells us. That is, if I say in Tamil, Marathu Poramari, that is not necessarily numbness, because the numbness as a technical term is different, and what we say is numbness is a different thing. Right. So you need to have a proper sensory motor testing to see whether there is a actual numbness, and also the pain, what they feel will be entirely different. If you don't understand what is nerve pain, I'm assuming every house there is somebody with diabetes, whether their uncle, aunt, or mother, or father, grandmother. So ask them how they a lot of people with diabetes after 10 years or something like that, they have pain in their leg. It will be, they will say that it is burning kind of sensation. That is actually a radiculopathy pain. So your pain will also be that type of pain. So because it is overdiagnosed, that is, every patient is said as that is non-specific back pain is classified as sciatica. You do something and the patient gets okay, and you think that you have treated sciatica. Actually, you have just done something and actually got better because it is a non-specific back pain.
Right. So the point that you're making is, one, if it is actually sciatica, which is again due to comes from the nerve root, Patients should have some form of sensory symptoms, which is related to some form of loss of sensation, varying degrees of loss of sensation. And they may also be a varying degrees of loss of strength. Some may not be detectable clinically
Correct.
because we really don't have that sensitive tools. And more importantly, the pain felt should somewhat resemble a pain that comes from a damaged nerve,
Yes.
right? That is sort of neuropathic pain,
Yes.
kind of what they should get. A
Yes.
neuropathic pain, or they are very typical, not the kind of pain where people usually say, I have a pain back in the, my thighs and so on. That is not exact. Neuropathic patient will say very specifically how they feel,
Yes.
sometimes burning sensation, pins and needles. And these are all typical neuropathic pain. So as I started in the beginning, most if you're having like there's a confusion about what is sciatica, right? So that means that we are possibly more likely misdiagnosed or overdiagnosing non-specific low back pain. Any non-specific low back pain that sometimes they feel it on the leg, back of the leg, as sciatica, without actually testing for motor, sensory, and along with neuropathic type of pain.
Yeah, when you say we, I'm not meaning physiotherapist. I'm meaning the neurosurgeon to the
Right.
orthopedist. Everybody is doing it. I don't have any qualms about saying that.
All health professional dealing with
Yes, they
back
don't
pain.
have the because they are either poorly educated or they don't have time or plain stupid. So this is not a problem with physiotherapists alone. It is a problem, overall problem, because we don't take the time to diagnose the patient. We don't take the time to take history. We don't take the time to do a proper examination to find what is wrong with our patient.
Yeah, and also the textbooks that doesn't get updated, and they just recirculate this form of information. I remember first time when I was introduced the term sciatica, it's an anatomy, as an applied anatomy, they say that there is a shooting pain, and
Right,
that's the term. And
right.
even today, if you really ask what is a shooting pain, I'm not really sure what it exactly means. But the point is, the textbooks and the teaching and everything, we thought it is so simple.
Very, very, very true. And also, I just wanted to add when you say that they all say that do an SLR test and you can find out.
Yeah,
SLR test is one of the nonsensical tests you can ever have. And also, these are not tests to be done separately. If you want to find out whether you have a sciatica, you need a group of hypotheses to be formed together, and then slowly you find out what is yes or no, and then come to a conclusion. It is not like, okay, do a COVID test, put a sponge inside your nose and take the specimen and then send it to the lab. It does not work like that. That is how it has become now. They take a film and they look at it and they say that
yeah.
sciatica, they do SLR, and that is not how it works. That is not how the textbook was also written. But sadly, some of the textbooks are written like that, and it is ruining us.
Right. So if you're really open about it, what I would suggest is, if you're having a clinic of look at the number of low back pain patients, the data suggests that we have about 5% or a maximum 10% of patients only is sciatica. But if you're treating like 10 low back pain patients per month, and out of them 5 are sciatica, uh, once the first explanation comes is maybe I'm getting more sciatica patients. But if you can be open about that, it's more likely that we are overdiagnosing it, because
That
that's
is,
what data suggests. Right?
uh, yeah.
Yeah,
Also, we should not have that big a disease left and right happening to us, right?
right. So moving on, okay, let us say that we have patients who are actually having sciatica with the way sensory motor symptoms, along with the pain that comes from some form of damage to the
Probably a proper history of fall or something like that.
right,
Also,
right.
sometimes
So
it isn't necessary, but it may help also.
yeah. So what can be done? What is the treatment for these patients?
I just want to add that mm, uh, you don't have to do a lot of assessment, but you just ask them VAs, tell them how much
Yeah,
pain they have. invariably they will be 6, 7, 8, 9, 10. Or it will be in the moderate to higher level. It will never be
7 to 10 maybe.
correct. So it will be in the higher region rather than in the lower region. Sometimes they may have less. So the first thing to understand what I'm trying to say is the pain is very, very high. And if you have diagnosed it properly as sciatica, the other thing to look into is if you see the prescription of medicine, what they would have prescribed, probably gabapentin kind of drug
Yeah,
might be
yeah.
the choice rather than uh, simple NSAIDs. So remember, gabapentin is also given to non-specific back pain because we are old now. But anyway, but when it comes to treatment of that, because we are assuming it is the disc has come out and then it has to be put in and things like that, which cannot be done because it's a biology. It is not a paper bag which you are putting your grocery inside. So the treatment is basically nothing. There is no treatment for a true sciatica. What I mean by treatment is non-pharmacological as well as pharmacological. They don't respond well. Sometimes the gabapentin might work for a few days, probably 3 weeks afterwards. They also don't mostly work. So the pain is there. That's what I told about. I highlighted the pain part of it. The pain is there, but very little can be done in terms of treatment.
So if a patient got a sciatica and they come to a physiotherapist, so what would a physiotherapist should do?
The first thing I would suggest is hmm, screen for red flags. The simplest screening you want to do is the saddle variety of sensory loss, if they
Right.
have. A lot of people don't do that, so they miss out whether it is the doctor or the physiotherapist, and ask them whether they can feel the sensation around the anal region. The easiest thing they tell you to ask is if you pass gas or when you're going stools, right?
Right.
Can you feel the expansion of your
Right.
the
Right.
rectal opening, right? So that is the first thing I would suggest if you have an idea that this seems to be like a scientific. And then ask them to be active. Activity and any exercise will produce some amount of pain relief. So any exercise, it doesn't matter whether it is a flexion exercise or extension exercise. Do all exercise. That is the basic idea you should have.
Generally, isn't that the opposite? Because it is presumed due to some form of damage, the first thing is to take rest or don't bend, don't lift heavy weight, and so on.
No, when I was told this, I asked my professor, okay, the first thing I do in the morning, right? I get up and I bend and take my brush and paste, and I bend and do that. Nobody is doing brushing like this. And he said, you have a lot of things to learn. He didn't tell me the answer, which I thought was a better idea than telling me the answer. So there is nothing you can do without bending. So the idea of bending itself is wrong. It's a myth that you can stop bending. The other thing is the biology is far more different than the mechanical system, where every time you bend, then uh, the disc comes out, and then it doesn't work like that alone. There are other structures which will stop it from getting worse. And also, even if it gets worse, they are not necessarily from the disc prolapse itself. So it doesn't work like that. So decompression or flexion extension, I mean, more of extension exercise does not make any difference.
Right. One might ask go to an extreme level, ask question. Does that mean that they can live any amount of weight? But the point here is whatever that involves in carrying out your daily activities, which may not further damage. But if your work involves lifting weight, a certain amount of that case, you might need to be a little bit careful. Would you agree?
Very much so. And also, why I have not talked about that specifically is even if you tell the patient to lift that weight, he will not be. That's why I told you the pain is it's
yeah,
7 to
exactly,
10,
right,
right?
yeah,
So his body will know that this cannot be done, or it will stop him from doing it.
right,
In our daily life, you and I, what are we lifting? The
yeah,
keychain which fell down?
exactly,
There's nothing to lift for us. So it doesn't matter if you're lifting 1 or 2 kilograms. But if you're lifting, say, for example, a bubble top and putting it
yeah,
on the top of your water bottle or something like that. I mean, not the bottle, but the
yeah,
can, I
you
suppose.
can,
So those things we may have to avoid, or the body will not allow you to do. Uh, common sense dictates what to do.
right. So on that note, let me summarize what we started off. First of all, the sciatica, not every pain that comes from back on the back of your low back and back of the leg is not necessarily sciatica. Sciatica, if because of the compression of nerve, so the logic goes the same, that any nerve that is compressed, because this nerve has motor and sensory fibers, obviously you need to have symptoms or signs and symptoms related to some form of loss of sensation and loss of strength. And in this case, if it's due to some form of damage to the nerve, you will also have a pain that usually represent damage to the nerve, some form of neuropathic type of pain. So that is how a sciatica needs to be seen. Secondly, if a patient has pain, such pain, if it's diagnosed that way, then the recommended treatment is to encourage them to stay active and reassure them by explaining what has happened or what is the likely uh, uh, recovery pathway, and possibly avoiding advices that can instill fear in them going lifting weight or so on. Anything else you want to add?
Yeah, I want to add 2 things. Then, what is the treatment for them? The resolution of pain and the chemical reaction which happens there, and slowly it goes away
Yeah,
anywhere from 6 months to 2 years, with or without treatment. That's what when we mean that there is no treatment, it does not mean that it will never get better. It means that the natural course of the treatment is as good as doing any fancy treatment.
and also having an MRI with the prolapsed disc does not automatically diagnose an sciatica. Like you got to have these symptoms along with that. Otherwise, it's just a disc prolapse or whatever for normal age-related causes. It can be many other reasons also.
Incidental finding more than anything. And also the other thing, I just want to clarify the last part of it. That is, why do we look for red flags? Because then sometimes we may have to have a surgery if the red flags gets worse, and so there will be one part of it we need to remember why we need to send them to neurosurgeon.
And also the type of pain you mentioned in terms of patients tends to have usually severe form of pain that significantly affects their day-to-day activities.
And also you want to know neuropathic pain in your vernacular, not in English.
Yeah. Okay, so on that note, we are ending this conversation. Again, let us know what are your thoughts, ask questions.
Yeah, bye-bye.
Bye.